Welcome to the third day of the Autistica Research Festival. I'm Charlotte and I work as a policy officer at Autistica. I'll be hosting this morning's panel session on healthcare. We've got 7 presentations on a range of important health-related topics. Unfortunately, autistic people face many inequalities and barriers within healthcare. Access is often inadequate, excuse me, because healthcare services have not usually been developed or designed to accommodate autistic people's needs or circumstances. We feel that more must be done to ensure that healthcare professionals have the understanding and knowledge to engage with autistic people in sensitive and supportive ways. So you can read about the speakers for the session just below the live stream, along with a PDF version of their slides if you wish to see them in a different format. All our speakers are going to be joining us at the end for a live Q&A once their presentations are finished. However, there's one change. So Katelyn Smalley is going to be joining us to represent Jade Davies's presentation. So you can submit any questions via the Q&A system, which you should see just below this video. The questions will be collated by my Autistica colleagues, and we'll try and get to as many of your questions as we can. Some of our presenters have agreed to let us share their email addresses, so if you have any further questions that we don't get round to answering, you can contact them there, and we'll also put those in the whole Q&A system after the whole panel session has ended. So we'll now start the session with our first presenter, Barry Ingham.
Hello, my name is Barry Ingham and I'm a consultant clinical psychologist working for Cumbria Northumberland Tyne and Wear NHS Foundation Trust. I work clinically with autistic adults and adults with intellectual disabilities. And I'm also an honorary clinical senior lecturer at Newcastle University, where I work on a number of different research projects looking at the development of assessments and interventions for autistic adults who experience health conditions. I just want to talk today about one of our projects, which is focused on looking at healthcare adjustments for autistic people and the development and evaluation of interventions to try and overcome healthcare barriers and improve the healthcare experience for autistic people. Just to set the project in context, there's an autism and adulthood research program that's been led by Professor Jeremy Parr and is a joint program with Newcastle University and my NHS Trust, and has been funded by Autistica on a number of projects within this research program, including the Autism Spectrum cohort and the Adult Autism Assessment Methods and Measures project, including the development of the Autism Clinical Interview for Adults, as well as a trial of psychological therapies for anxiety experienced by autistic adults. But the project that I'm particularly going to focus on is the Improving the Health of Older Autistic People project. And I'm also going to mention our Health Checks for Autistic People project. And there's a couple of links there for people to follow if they want to find out a bit more information about the studies and projects that we're undertaking. So moving on then to more about the Improving the Health of Older Autistic People project. Now this is a project that was funded by the Ingham Wakehurst Trust and was a partnership between CNTW NHS Trust, Newcastle University and the National Autistic Society. And this is a project that was set in the context of, as we know, autistic people experiencing more health conditions and premature mortality, and also difficulties that autistic people may have in accessing effective healthcare. So the aims of this project were firstly to identify barriers and boosters to accessing healthcare for autistic people, and then secondly, develop and test a tailored healthcare adjustment approach for older autistic people. So there's 2 stages to this project. The first stage was an exploratory stage to identify barriers and boosters to healthcare, and also to design an intervention to try and facilitate access to healthcare. And we did literature review, survey, interview, and focus groups within that stage. And then the second stage was the development, or the evaluation of the intervention that was developed in the first stage, and a feasibility trial to look at how acceptable a trial of this intervention might be. So we focused on recruiting older autistic people experiencing co-occurring physical health conditions, and in this context, older men, and then also implementing the tailored healthcare adjustments intervention, which I'll talk about a little bit more detail in a second, and then some evaluation of how people experience that process. So I just want to talk a little bit about the stage 1 outputs. So this was the exploratory stage where we did a systematic review of the barriers and facilitators to healthcare access. We did interviews and focus groups with autistic people and clinicians around facilitators to healthcare access. And then we also did a survey of autistic people on their view of what's important in terms of adjustments to healthcare services, and where some of the gaps are at the moment in terms of the provision of those adjustments. And those studies identified a number of different areas where there are barriers to healthcare access, such as difficulties in communication between clinicians and autistic people, sometimes a lack of training in autism for clinicians delivering healthcare, and clinical settings not always being appropriate to the needs of autistic people, particularly thinking about sensory differences that autistic people may experience. So we used that information to design healthcare adjustments intervention. And the tailored healthcare adjustments intervention was a process where we had initial sessions between the autistic person, the participant, and a qualified healthcare professional, which started with a getting to know you assessment to get a better idea of the sort of adjustments that a person might need to healthcare, and then also thinking about how those adjustments could be put into practice with both the participant and the healthcare providers that they may be accessing. So we looked at feasibility of this intervention, feasibility of trialing this intervention through a single-arm open trial, and we assessed that through looking at recruitment and retention rates. We managed to recruit 24 older autistic people. Of that group, 3 people withdrew prior to intervention. We had 16 males and 5 females within that group. There's a little bit more there about some of the demographics for that group, including age and scores on the social responsiveness scale. 3 people withdrew prior to follow-up, so we did have some loss of people through the trial, but we still had the majority of people retained within the trial. Some of the reasons for attrition and people lost within the trial were mainly physical health related, so we could understand why people may have dropped out of the trial, and it was more about their own health conditions rather than the trial itself. At the end of the trial, we did some semi-structured interviews that were aimed at assessing acceptability of the intervention and the trial process. We also did some quantitative measures and data collection, which were mainly for the purposes of this trial about understanding what autistic people and participants may accept in terms of measures and approaches to data collection. So I just want to focus a little bit more now on the outputs from the semi-structured interviews that were conducted. We did a thematic analysis of these interviews that was independently coded by 2 raters, and we found 3 main themes with sub-themes within those 3 main themes. So the 3 main themes being reasons for participation, feasibility and acceptability, and attitudes and approaches to healthcare. So I'm just going to look at some of these themes in just a bit more detail to give you a sense of what participants were saying about the intervention in the trial. Firstly, the reasons that autistic people gave for participating. Within this theme, there were three sub-themes. The first sub-theme being people feeling that it was something that was helping themselves. Participants often reported they wanted to gain insight into autism, talk to someone who wanted to understand their autism. For example, one autistic person said, "I thought I might be able to help. I thought I might be able to get some insight into myself." The second sub-theme was helping other autistic people. So many people wanted to contribute to help other people. They also wanted to give autistic adults a better chance of receiving help. So another quote here is, "I don't believe there's enough for autistic adults, so I wanted to try and help in some way." And thirdly, third sub-theme was raising awareness. People wanted more people to understand what it's like to live with autism. So a couple of quotes here. Well, I just think that people need to understand how difficult it is for autistic people, just for everyday things, basically. And it would be nice for them to have an understanding about this. So moving on to the second main theme, feasibility and acceptability of the intervention and the trial process. So the first sub-theme here is ease of completing assessment measures. The process of the getting to know you and baseline assessment went well because care and consideration was given. A quote here was, "Going in and discussing it and talking through the questions, that's absolutely fine because I was able to, sort of say this question fits me better and I can give you that answer. Whereas if it had just been a written thing, you wouldn't have got an accurate answer." The second sub-theme is the importance of adapting the assessment environment. Research communication made it easier to take part and complete the assessments when the clinician was sensitive to participants' needs. So a quote here is, "No problems at all. It wasn't in the main hospital, which is good. It was in the old part, which is more relaxing. So yeah, and the clinician had all the lights off because I'm a bit light sensitive, so no problem." And then the therapeutic benefits of completing assessments as a third sub-theme. A quote here, "It made me understand more about myself because when you're inside yourself, if you see what I mean, and you can sort of can't see the outside of yourself." And then the third theme is attitudes and approaches. So here, the first sub-theme was importance of clinician communication. So one quote is, "Yeah, it's made me feel more at ease with him and he's understanding. I can explain myself better to him if he's asking the questions." Another quote, "The fact that the clinician has also put on there that it helps me to give advance notice of the questions. Perhaps when I do have to go for hospital appointments, they will give me advance notice, in which case I will get more from the appointments, which should help in the long term." And then the second sub-theme here is changes in participants' own approach to healthcare. So it's helped me quite a bit because I feel, there's something in place. Hopefully these GPs will acknowledge us and put it into practice. But in that sense, I feel better about it. And also now I feel I can go to a GP if need be. So, in summary, there are significant barriers to effective healthcare for autistic people. Autistic people have identified ways of overcoming these barriers. These are not being provided currently. We're developing and evaluating ways of helping healthcare systems to change and overcome barriers. This includes regular health check and a more intensive tailored healthcare adjustments approach. We're currently undertaking a health check for autistic people trial, and we're also supporting the healthcare system to plan a rollout of health checks within routine practice. This is a list of our contributors and also references, which include some of the papers that I've mentioned today. Thank you very much. I'm going to hand you back to the panel chair, and there'll be an opportunity to ask questions at the end of the panel. Thank you.
Thank you, Barry, for taking us through all the research that you and your team have done on ways of improving access to healthcare for autistic people, which is so important for people's health and quality of life. We'll now move on to our second speaker, who is Jade Davies from the Centre for Research in Autism and Education at UCL.
Hi everyone, my name's Jade Davies and I'm a research assistant at the Centre for Research in Autism and Education, which is based at UCL's Faculty of Education and Society. And today I'm going to be talking about our research that looked at how to maximise the uptake of health checks for autistic people, and specifically how we can encourage GPs and other primary care professionals to implement annual health checks. I'm going to be presenting with Dr. Katelyn Smalley today, who will also be at the live Q&A session, as I unfortunately can't be there. Okay, so to start with, I'm going to talk a little bit about why annual health checks might be important before I go on to talk about our research and our key findings. So we know that there are huge health inequalities for autistic people. So for example, autistic people have higher rates of almost all mental health conditions when compared to non-autistic people. And autistic people are also more likely to have physical health conditions too. So things like cardiovascular disease and physical disabilities. And unfortunately, we also know that on average, autistic people die around 16 years earlier than non-autistic people. And one of the suggested reasons as to why these health inequalities exist is that healthcare can be really inaccessible, which means that autistic people can struggle to access the care that they need. And research with autistic people has tried to identify some of the specific barriers that autistic people might face when trying to access care. And some of those barriers include things like the sensory environment, so often GP practices are quite noisy and quite artificially bright. And a lot of autistic people have also highlighted a general lack of knowledge and understanding from their GPs about autism, and have highlighted that a lot of GPs' knowledge is grounded in the medical model of autism. And this means that a lot of autistic people don't access medical support or don't go to their GP until their health has deteriorated or until they've got really sick. And one suggested solution is that all autistic people could be offered with an annual health check. So annual health checks are yearly checkups that aim to assess somebody's overall health and well-being. They often include a physical and a mental health component and ultimately aim to lead to an earlier diagnosis and treatment of conditions. A range of groups are currently offered annual health checks, so those groups include people with learning disabilities and those with a severe mental illness as well. And research with these groups that already receive these health checks paint a really positive picture. So we know that providing annual health checks can lead to the detection of unmet health needs, they can improve overall patient quality of life, and lead to a reduction in preventable hospital admissions. So they can have really positive outcomes. But we also know that the implementation of these health checks is really varied. So if we take learning disability health checks as one example, nationally, less than 50% of those on the Learning Disability Register actually receive the health check that they're entitled to. So we clearly have an issue in terms of implementation. You know, we can develop a really fantastic health check, but if they aren't being implemented, then we aren't likely to have the widespread positive impact that we want. And this really formed the basis of our research. So we wanted to understand GPs and other primary care professionals' beliefs about the kind of barriers and facilitators that might be involved in them implementing or not implementing annual health checks for autistic people. And we wanted to take this a step further. So based on those barriers and facilitators, we wanted to be able to identify or develop a series of policy options and recommendations that could really work to encourage GPs and other professionals to implement the health checks. So we did this over 2 phases. In the first phase, we spoke to a series of primary care professionals, so that's GPs, nurses, healthcare associates and so on, and autistic people. And we asked all of them about their experiences. So for autistic people, that was their experiences of going to their GP, and for primary care professionals, that was their experiences of providing health checks for other groups. And we also asked all of these people about their perceptions of health checks for autistic people. And the findings from phase 1 informed the development of a national survey that almost 200 primary care professionals responded to. And I'm going to highlight some of the key findings over the next slides. So promisingly, there was a lot of enthusiasm for the health checks, and that both came from primary care professionals and autistic people. As you can see on the slide, there's a quote from an autistic participant that said that they would be in favour of anything that stops medical conditions from getting to the point where they're so bad that they can't be ignored. And that largely was the perception of our autistic participants. They were positive and they welcomed the health checks. They did, however, note that some autistic people might not want a health check, especially if they'd had quite poor experiences with their GP in the past. Interestingly, GPs seem to be somewhat less enthusiastic about the health checks than participants with other job roles, so nurses, healthcare assistants and so on. But that could have been linked to the fact that GPs also said that they had less time and less staff to be able to offer health checks than those other participants. Perhaps unsurprisingly, our GPs and other primary care professionals said that they felt overstretched, under-resourced and undervalued, and I think the two quotes on the slide here really do a good job of demonstrating that feeling. So at the top you can see one GP said that it feels like a luxury to be able to offer that, and I think this really does show that people did want to be able to offer these health checks, but it just did not feel like it was accessible or viable given the kind of resources that GP practices did or didn't have. And something that came out quite a lot was that GPs felt they would have to remove another service to be able to offer health checks for autistic people. And this was particularly the case in the context of COVID, where efforts were sort of being moved towards the vaccination programme and moved away from these kinds of health checks. And finally, GPs surprisingly did highlight that they lacked quite a lot of knowledge when it came to autism. And I think you can see in the top quote that GPs' knowledge is not as good as people think it is, particularly with something like autism. And there were a few key areas that our participants highlighted where there was a real lack of knowledge. So things like the healthcare needs of autistic people, how best to communicate with autistic people, and the kinds of barriers that autistic people might face in accessing healthcare. And as a result of those uncertainties, some participants were not sure if annual health checks would be beneficial, and they really wanted to see some clear evidence before they would implement health checks. So that's a kind of whistle-stop tour on our key findings, but I'm going to hand over to Katelyn now, who will quickly talk about some of our key recommendations.
Thanks, Jade. As Jade mentioned, it was really important for us to not only understand the context in which health checks would be offered, but also to provide some practical solutions to address the barriers that we identified and use the facilitators to increase the likelihood that GP surgeries will take up the new policy. We also recognize that local conditions can influence a practice's ability to make changes. For this reason, we've offered options for different ways that a surgery could respond to each recommendation. We have three main recommendations, which I will take you through now. First, we recommend that health checks for autistic people should be delegated to the extent possible to non-GP health professionals. In our study, GPs were very concerned about having enough time to take on new health checks and still manage to do their other work. But non-GP professionals were more optimistic about their capacity. Our participants were unanimous that health checks were within the professional capabilities of nurses, and some parts could even be completed by other staff members. For this reason, we think that formalizing annual health checks as a special role for practice nurses, so part of their job description, or providing dedicated time to conduct them, could be an important way to involve non-GP professionals in providing this new service. NHS England could consider providing specialized training, qualifications, or pathways for job progression to encourage people to take on these new roles. On the other hand, practices may consider that health checks do not need to be undertaken all in one go. Checks could be divided amongst multiple staff members to lighten the load. We think that it would be important to consult with more autistic people on this one, though. While some of our participants liked the idea of spreading a health check over a longer period of time, others weren't so keen to come into the office multiple times or preferred to work with only one person. Our health professional participants consistently told us that their biggest barrier was time. We think that addressing some of the logistical challenges that they raise can be a helpful time-saving strategy. For instance, scheduling could be automated to reduce the administrative burden of arranging appointments for everyone. NHS England could also provide templates and checklists to make sure that conducting and documenting health checks is as easy as possible, and to make sure that all of those documents reflect the same process. We think it's important that these should be co-developed with autistic people and frontline workers to ensure that they reflect both the needs of the people who will be receiving the health checks and the working patterns and other limitations of the people conducting them. For similar reasons, our participants preferred, for example, for existing payment structures to be used to pay for health checks, so that they wouldn't need to spend time learning a new system and could instead focus on patient care. Finally, we recommend that NHS England needs to support the development of an evidence base that demonstrates both the need for tailored approaches to healthcare for autistic people and the effectiveness of annual health checks specifically in addressing those needs. As Jade mentioned earlier, in the context of having too much to do and not enough time to do it, some of our participants were skeptical that annual health checks would be the best use of their time. With that in mind, we recommend developing and disseminating evidence on the positive impacts of health checks, how they address the unique health needs of autistic people, whether autistic people feel that they have improved their ability to get the healthcare services they need, and whether these positive experiences have translated into real health gains, including identifying and treating health problems early. Again, we stress that this evidence base should be developed together with autistic people, and autistic adults should be involved in educating health professionals on best practices. Thank you so much for your time and interest in our research. I'm now going to hand it back over to the chair of the session, who will introduce the next panel presentation. I'm really looking forward to answering all of your questions about this work. Please save those questions for the end of the session, and we will discuss during the live Q&A. Thank you.
Thank you so much, Jade and Katelyn, for showcasing your important work on health checks. As some people in our audience might be aware, health checks are one of Austica's policy goals, so we really appreciate you sharing your work on this with us and with our audience today. We'll now move on to our third speaker, who is Rachel Moseley.
Hi there, I'm Rachel Moseley and I'm a principal academic at Bournemouth University. This talk focuses on a study by myself and my colleagues on the topic of lifetime stress and its associations with physical and mental health in autistic adults. So when we talk about stress in our daily casual conversations, we're generally thinking about a feeling of tension, of being under pressure or overwhelmed. However, when scientists talk about stress, we're talking about a biological and psychological change that happens within an individual when they encounter something in their environments which they perceive as threatening. The thing that provokes that stress response is called a stressor. And when you experience stress, the brain launches a biological fight or flight response, which is incredibly ancient and adaptive in the short term. For instance, if you needed to escape from a lion. But when we talk about stress nowadays, we're generally thinking about things like deadlines, juggling demands, social pressures, things that seem mundane in comparison to lions, but which hold very significant threat to us at an emotional or social level. They might not even be happening right now, but because we can imagine them, we can't easily escape them. So we feel that stress response as if we actually were under threat. And if the biological stress response keeps going over long periods of time or keeps being activated, it can suppress your immune system and damage your body and brain, increasing your risk of serious mental illness and physical illness like cardiovascular disease. This is massively relevant when it comes to autistic people because of several known facts. Firstly, we know that autistic people objectively experience more traumatic life events than non-autistic people. Secondly, we know that autistic people often experience daily life events as more stressful, as well as experience traumatic events as more stressful. And thirdly, we know that autistic people have higher rates of many chronic and serious illnesses, and that they die earlier on average than do non-autistic people. Despite these facts, we know very little about the contributions of stress to mental and physical health in autistic people. So in this study, we aimed to pilot a novel assessment tool, the Stress and Adversity Inventory, or STRAIN. It's an online interview-based assessment tool, fully automated, which asks about a range of different kinds of life events, when they happened to you and how badly they affected you. And in the general population, the strain has been used to make very detailed predictions about people's health based on what life events they experienced and how severely they were affected. And it can significantly predict things like specific stress-related illnesses and pathological processes. We use the strain to look at relationships between lifetime stress and measures of general physical and mental health in autistic people. We also wanted to see if in autistic people, as in the general population, there are factors that might affect whether or not someone perceives a life event as stressful. Social support is a really important example of this. So in non-autistic people, having strong social support can reduce the likelihood that you will perceive a life event as stressful. Furthermore, even if you do perceive a life event as stressful and you're experiencing a stress response, support from your family and friends can help you cope and therefore not suffer such a prolonged stress response. In contrast, being highly lonely seems to really worsen the impact of stress on your health. So we wanted to see if this was also true in autistic people. So we asked 127 autistic adults and 102 non-autistic adults to complete the strain, along with some measures of loneliness and social support, symptoms of general physical health, so recent exposure to bugs and stomach bugs and viruses, and recent symptoms of mental illnesses like anxiety and depression. Our autistic group were on average around 40 years old, all cisgender and mainly women. Our non-autistic comparison group were age-matched and contained similar proportions of cisgender men and women. About half of our autistic sample had some kind of employment at the time of the study, and over half had a university degree, so they were a highly qualified sample. However, they had very high rates of mental illness, especially anxiety and depression. And our first key finding was really a group comparison that showed that, as expected, autistic people experienced more of every kind of life stressor assessed by the strain, and they also rated these as significantly more stressful than did the non-autistic group. So this figure shows the average number of stressful life events experienced by our autistic and non-autistic participants. And you can see that stressor exposure is especially disproportionate in the areas of housing, work, treatment and health, romantic relationships, friend and family relationships, and life-threatening incidents. In terms of health, we found slightly different things for physical and mental health. For non-autistic people, their perception of life events as stressful rather than the number of life events they experienced predicted their recent physical health. For autistic people, although they experience life events as significantly more severe, this didn't predict their recent physical health. We have to treat this finding with caution because our measure was just looking at quite generic, mild health complaints. But it's possible that because there are so many factors which contribute to poorer physical health in autistic people, that the link between stressful life events and physical health is less obvious. So poorer physical health in autistic people could be related to sleep disturbances, medication side effects, being unable to access healthcare, many different things. However, since it's possible to link specific stressors with specific illnesses and pathological processes in non-autistic people, it might well be worth looking at this again with a more precise and specific marker of physical health. For mental health in both groups, the impact of stressors on health was mediated by perceived stressor severity. So basically, if you experienced more stressors, you tended to experience them as more stressful, and it was your perception of life events as stressful that was actually related to having poorer mental health. Being autistic alone was associated with having poorer mental health, and certain stressors seemed like they might be especially important for mental health in autistic people. So life events involving the loss of someone close to you, feelings of being trapped or helpless, and feelings of role change or disruption, like needing to depend on aging parents or a romantic partner for support needs. We then looked at whether loneliness and social support did anything to worsen or cushion the health impact of life stress. In all participants, loneliness was associated with a tendency to perceive life events as more stressful. But we also found that loneliness wholly explained the relationship between being autistic and having poorer mental health. In contrast, for people with high levels of social support, there seemed to be a buffering effect where social support lessened the impact of the biological stress response on mental health. However, we did also find that having higher levels of social support did not protect autistic people from perceiving life events as more stressful in the first place. It might be that this is because autistic people tended to perceive life events as more stressful, no matter how much social support they had. But it's also intriguing because it might suggest that accessing social support is itself stressful for autistic people. We know that in the general population that having a lot of social support can protect a person from perceiving life events as stressful in the first place, but this wasn't the case for our autistic participants. So we must treat the findings with caution insofar as the strain is a self-report measure which relies on memory. So it would be very important to validate these findings with additional biochemical indications of stress levels, like stress hormones, as well as looking at more precise and specific outcome measures. Because the strain was designed with non-autistic people, it likely doesn't include a lot of stressors that might be really relevant for health in autistic people. And our highly qualified, late diagnosed autistic sample, who were mainly cisgender women and white British, were not representative of the whole autistic population. Finally, there's so many determinants of health that we did not control for, such as socioeconomic status and health behaviours, and a full picture of health in autistic people really requires considering a multitude of interacting variables, from the genome to bodily systems to the social environment that autistic people live in. Our final messages are that the perception of life events as stressful is what impacts on mental health. There's no argument that social change is needed to address the inequalities that autistic people face that make them more likely to experience stressful and traumatic life events. But this also gives us another avenue to tackle their mental health impact by supporting people by intervening at the level of perception with interventions that might make them less likely to perceive life events as stressful and therefore less likely to be in a state where their body is constantly experiencing a stress response. Loneliness is a massive factor in the mental health of autistic adults, as we found here. And social support seemed to lessen the impact of experiencing stress on mental health, but it didn't protect autistic people from experiencing things as stressful in the first place. This might simply reflect that support was insufficient, or it could be that obtaining it incurs a cost of its own. Thank you so much for listening, and to my participants for taking part. I'll now hand back to the chair, who will introduce the next speaker, and I'll happily answer any questions in the live Q&A.
Thank you, Rachel. I think there will be a lot of people who really appreciate your research into the impact of stress on autistic people's health. There's so much still to be learned about the health issues that autistic people face. We'll now move on to hear from Susan Simmons from UCL.
Hi everyone. Just to introduce myself, I'm a parent of an autistic adult and a part-time PhD student at the Division of Medicine in UCL. The title for this presentation is The Effect of Gastrointestinal Symptoms on Autistic Children, a Qualitative Study with Parents and Carers. I will refer to gastrointestinal symptoms as GI symptoms throughout the presentation. I will talk about the impact of persistent GI symptoms on the child and their family, the nature and severity of GI symptoms in autistic children and the family experience of access to related healthcare, the unmet healthcare needs and parents' suggestions for service adaptations. Kindly note, this research is not yet published, so please don't circulate it. This research was done as part of my PhD and was also part of a larger research study at University College Hospital, London. We conducted 12 in-depth interviews with the parents or carers of autistic children with persistent GI symptoms. The participants' children ranged in age from 5 to 15 years and had a variety of GI symptoms and dietary habits. 8 of them were boys, 4 were girls, and they were geographically spread out across England. Importantly, the parents and their autistic children were consulted on the topic guide for the interviews. So 4 major themes emerged from the thematic analysis of the interview transcripts, which are listed here. I will cover each of these in detail in the coming slides. There are some speech bubbles on some of the slides, and these are quotes from the interviews to illustrate the findings. Theme 1 is that GI symptoms impact on many aspects of the lives of autistic children and their families, and the impact tends to increase with age. Most of the children had suffered GI symptoms for several years, and this had impacted their physical and mental health. Some parents reported that their child regularly suffered abdominal pain or pain when passing a bowel movement. This often resulted in the child withholding bowel movements, which can then lead to bladder incontinence and a lack of proper bowel sensation. One child had recurring vomiting, which had a devastating effect on their dental health. Some children were anxious or self-conscious about their GI symptoms and didn't want to engage in social activities. As you might imagine, this became more of a problem as the child got older. GI symptoms also affected the children's independence, mood, sleep, and appetite. All the children were unable to use a toilet outside the home for bowel movements, and this affected family activities and holidays. It also meant that they were holding on all day at school with subsequent discomfort. The children's GI symptoms and pain were a source of stress for their siblings and parents. Some parents found it isolating managing their child's GI symptoms on their own, as it was not a subject they wanted to talk about with other parents. There was also a financial burden in managing incontinence for some families. Without formal guidance, parents are doing their best to help their child's GI symptoms using various lifestyle measures, without any real evidence that these can help. Theme 2 is that understanding the nature and severity of GI symptoms in autistic children is complex and multifactorial. The majority of the children developed GI symptoms as an infant, and most parents reported that toilet training had been difficult and took a long time. This reflects research that around half of the autistic children are not toilet trained at age 4 years, and toileting resistance is more common in autistic children than in similar aged children with developmental delay. Parents reported that there was a huge sensory aspect to their child's GI symptoms. They reported a number of behaviours that were indicators of GI distress in their child, including jumping up and down, self-injurious behaviour, more meltdowns, being cross or aggressive, sleep disruption, and an increase in autistic traits. This chimes with qualitative research from the USA that found parents relied on behaviour and bodily signs as indicators of GI distress in their autistic child, even if the child was verbal. Parents in our study were often uncertain about the specific nature and severity of their child's GI symptoms. They were worried about their child suffering pain and discomfort without them knowing. Some found it difficult to know when to seek medical advice, or worried about not being able to tell the doctor what was wrong. Parents reported a number of factors that they felt were interconnected with their child's GI symptoms. Analysis of the interviews and relevant research literature suggests a complex, interwoven picture. We don't have any longitudinal studies on GI symptoms in autistic children that have proven causality either way, but many studies have reported on the correlation of GI symptoms with various aspects of behaviour, sensory issues, mood and sleep. The picture is complex and even appears to be different for different age groups. A recent study by Dovgan et al. Found a bidirectional relationship between GI symptoms and internalising behaviour, such that they simultaneously affect one another. They concluded that in order to resolve either GI problems or internalising behaviour such as anxiety, clinicians should consider treating both. Certainly, clinicians need to be aware of this complexity and to consider it when assessing and treating GI symptoms in this patient group. Theme 3 is that access to healthcare services for autistic children with GI symptoms is variable, often limited, and with diagnostic overshadowing. There was a lot of variation in the type and level of support and services experienced by participants. For the majority of families, the only health professional, if any, regularly involved in the management of their child's GI symptoms was their GP, and this was often just for repeat prescriptions. Many parents felt they had been left on their own without guidance to manage their child's GI symptoms. Things that contributed to this feeling were long waits to receive services, long spells between appointments with no access to advice between appointments, a lack of active follow-up by health professionals, and services being age restricted. Parents felt that GI symptoms were often considered to be part of autism, and therefore their child was not offered any diagnostic evaluation or treatment. And this is what is known as diagnostic overshadowing. Others found that the NHS system was not set up to address the health complexity seen in autistic children, which may span several medical specialisms. They felt there was a need for a patient-centred, more holistic treatment approach that would take account of the sensory sensitivities of autistic children, as well as the complex interplay between GI symptoms and other aspects of health and functioning. Unfortunately, the majority of the families reported a poor experience of healthcare for their child's GI symptoms, and few had been offered adjustments to the service to make it more accessible. Some of the parents and children had been quite traumatised by previous visits to various healthcare appointments, and this led to some reluctance by the parents to seek medical help and anxiety in the children about any kind of medical appointment. Theme 4 is that reasonable adjustments to the current NHS service can reduce child and parent stress. This is a summary of parent suggestions for adjustments. Parents wanted to understand their child's GI condition and the treatment plan. They wanted clinicians to be open with them about the long-term plan for managing their child's GI symptoms and the possible health implications of the condition and the treatment. They also wanted clinicians to listen to them more about the sensory issues with taste and texture of medication. The interviews for this study were done during COVID-19 lockdown and restrictions, so most parents had experience of phone or video consultations with their doctor. These were not the preferred option for all parents, but some parents found them a lot less stressful and would prefer this option going forward. Other research done with autistic adults suggested double appointments, appointments at the beginning or end of the day when the waiting area should be less busy, and keeping to appointment times. From our research, suggestions to reduce anxiety and stress for the child were information, including photos, on what will happen at the appointment, who they will see, and where they are going. A peaceful waiting area with reliable Wi-Fi was also important. One family's experience perfectly illustrated how helpful it can be when the clinician adjusts their communication style to the child's ability and interests. This can build trust between the child and the doctor, improve patient engagement with the treatment plan, and improve the child's self-esteem. The stepped care model is a model already used in mental health and has been proposed for health and social care for autistic individuals. It is a framework for organising healthcare, and one of its objectives is to provide the right level of support at any stage and so avoid a healthcare crisis. Considering the results of this study and relevant research, these are my thoughts on a possible stepped care model for autistic children with GI symptoms. I'm not going to talk through this, but I will just explain that the ASD GIRBI is a recently developed autism-specific assessment tool for GI symptoms that collects information on behaviour as well as GI signs and symptoms. I hope that the results of this research can contribute to a new model of healthcare for autistic children with GI symptoms. To summarise our results, Gastrointestinal symptoms impact on many aspects of the lives of autistic children and their families, and the impact tends to increase with age. Understanding the nature and severity of GI symptoms in autistic children is complex and multifactorial. Access to healthcare services for this group is variable and often limited, with diagnostic overshadowing. Parents have suggested adjustments to current NHS services that can reduce stress for the child and the parent and increase accessibility for this group. Finally, a big thank you to all the study participants and our sponsors. Thank you for your interest in my research, and I will be happy to answer any questions in the live Q&A later. I'll now hand over to the chair of this session, who will introduce the next panel presentation. Thank you.
Thank you, Susan, for your hard work to find out more about the impact of these symptoms experienced by so many autistic children. I'm sure we'll have a lot of interest in your presentation among our audience. We'll be moving on now to our next speaker, who is Kate Cooper, who will be sharing her research from the University of Bath.
Hello, my name's Kate Cooper and I'm a lecturer and clinical psychologist based at the University of Bath in the Centre for Applied Autism Research, and I'm presenting to you today my NIHR funded research, The Lived Experience of Gender Dysphoria in Autistic People. And I've been really lucky to be supported by some brilliant people whilst working on this project, including the Spectrum Support Group, which is a group of autistic and transgender people, my academic supervisors you can see listed there, and all of the images you'll see in this presentation were designed by Andy Thornton, a brilliant non-binary and autistic artist. So why is this an important area to research? Well, we know that there are some people who experience gender dysphoria, which is distress due to one's gender identity and body or sex assigned at birth not matching. And some people experiencing that distress choose to go to gender clinics in order to get support for that distress. And we know that autistic people are really overrepresented in those gender clinic settings. And we also know that in general, autistic people and gender diverse people are likely to receive poor healthcare compared to others. But there's really a limited evidence base to guide clinical practice for supporting this group at the moment. In this project, we aim to answer the question, what is it like to be autistic and experience gender dysphoria? And to answer that question, I conducted interviews with these 5 different participant groups. So I spoke with autistic young people who had experience of gender dysphoria between the ages of 13 and 17, the parents of the young people. I also spoke to autistic adults who had experience of gender dysphoria, and then clinicians who work with gender diverse and autistic people of both age groups. The interviews were either in person or online, and I used autism adaptations throughout the interviews to help with communication between me and each participant. I conducted a total of 68 interviews, so you can see there that I interviewed 21 adults, 15 young people, 16 parents and 16 clinicians, 8 who worked with young people and 8 who worked with adults. For the young people, the interview was separate for the young person and parent, unless the young person wanted that parent in the room with them, if it made them feel more comfortable. And the interviews really focused on the question we're talking about today. So what is it like to be autistic and experience gender dysphoria? And I also had a second part of the interview, which was more about accessing healthcare as a trans autistic person. And then I analysed the interviews using a qualitative methodology called interpretive phenomenological analysis, or IPA. And with this method, there is a real focus on the meaning to the individual of their experiences, so how they have made sense of the experiences they've had. It's an ideographic approach, so it takes a real individual approach to the analysis with a focus on each individual's experience before summarising across each group. And I used a multi-perspectival design, so that means that I was comparing findings between those 5 different groups that I described to you a minute ago in order to generate a really robust understanding of the phenomenology of gender dysphoria across different participant groups. So this is just an overview of the themes which were developed from that analysis. And there were two overarching themes. So the first was discovering gender identity, and the second was the complexities of moving towards gender comfort. So the first overarching theme was discovering gender identity, and the first part of that was gender as deeply known and central. And one way that participants described really knowing in a deep way about their gender identity were these quite significant experiences of distress in relation to a mismatch between one's body and gender identity, and that making people feel very certain. So one participant said, "I always think that it'd be a lot easier if I was female on the inside and the out instead of boy inside and then the female out." And then another part of gender being seen as something that should be deeply known and central was that at times when participants felt uncertain about their gender identity, that was really distressing. So a lot of people felt that you should be certain about your gender identity at all times, and it was upsetting when it wasn't. So for example, this participant said, "For me, in everything I do, in everything I think, there has to be some sort of like definitive truth to everything." And so like I said before, I had a doctor who said, "Do you feel like a woman?" Well, I don't know what a woman feels like because I wasn't born one. I'm not happy with saying yes, I feel like a woman when I don't have every available fact. And then the second part of this theme was the role of autism in developing self-understanding, and there were quite different perspectives across different groups. So the young people I spoke to often distanced themselves from their autism diagnosis. So one young person said to me, "It's not like I'm walking autism and that's all there is to me." And often young people were much more willing to discuss their gender identity, but didn't really want to talk about autism. Adults, on the other hand, were up for talking about both autism and gender identity and saw both of those things as an important part of who they were. And for that reason, they often spoke about the intersections between being autistic and experiencing gender dysphoria. So there's a quote from one adult here saying, "I think there are intersections, but I don't think it, autism, completely jades my perception." So both groups, autistic adults and young people, were really clear that being autistic didn't impact on their knowledge about their gender identity. On the other hand, parents of young people and clinicians working with the young people sometimes wondered about how autism might actually contribute towards the young person having a transgender identity. So one parent said, "The biggest factor is there are other issues and the sensitivities they have around their autism, which I think swamps a lot of other things." So there was a sense of parents really focusing on autism-related needs, sometimes more than gender-related needs. And then a clinician who works with young people said, "I felt my work was often about wanting to help them have a kind of richer sense of their gender experience, to help them link it with other aspects of their lives, like their autism." So the second overarching theme was the complexities of moving towards gender comfort. And the first part of that was about how the features of autism could sometimes compound gender dysphoria. And there was relative consensus across different groups regarding this. So both autistic adults and young people described how sensory sensitivities could enhance difficult experiences around puberty and experiences of gender dysphoria. So one adult said, "I was stuck between having really bad gender dysphoria, not wearing a binder, or feeling really uncomfortable sensory-wise." And then a parent described their child's experience. "I think with the fact that his body went from being similar to his brother's to having a chest and having periods, I think has really thrown him. He's no longer in control of his body." So there's this sense that being autistic and the sensory sensitivities that come along with that really contributing to additional difficulties on top of those that you'd already experienced with gender dysphoria, with your body changing in ways you don't want to. And on top of that, difficulties with managing change and uncertainty and rigid thinking could make that even more distressing for some participants. So the second part of this theme was clinical services as a perceived barrier. And whilst autistic people described needing adaptations in clinical settings to improve communication between them and clinicians, clinicians also described struggling to understand their autistic patients and how to communicate. So evidence of the double empathy problem in gender clinic settings. And an autistic adult said of their experience in a gender clinic, I feel like my autism kind of gets ignored in a way. With my autism, I kind of need things explained and stuff like that. They just make no kind of alterations at all. So in conclusion, in this research, we found that autistic people were really clear that they knew their gender identities, but sometimes clinicians working with young people and parents of young people were concerned that autism might influence the way in which gender identity develops. And there was more consensus when it came to the ways in which the features of autism might compound experiences of distress in relation to gender incongruence, and also on the fact that autism adaptations are really needed in gender clinic settings to improve communication between clinicians and autistic patients. And I've put together some training resources for clinicians working with autistic people with gender dysphoria. So there are 2 videos which are available on the website here. They are password protected because the videos are intended for people with clinical qualifications and experience only. But if you would like access to those videos, please do send me an email and I can send you the password. And something else available to everyone on the website is a form that I co-produced with the Spectrum Support Group, which is an information sheet people can fill out before their first appointment in any clinical setting, really, sharing information about their autism and adaptations that might need to be made to make their appointment more comfortable and accessible. And this could be used in a really wide range of healthcare settings. So please do download the PDF if you think it might be useful. Thank you so much for listening. And if you have any questions at all, please do feel free to contact me on the email address on screen.
Thank you, Kate, for raising awareness of the lived experience of gender dysphoria through your research, and also for introducing those online training materials and tools that have been developed that I'm sure will be very useful for many people, and lovely illustrations as well. Our next speaker is Esther Whitney, and Esther will be talking about autistic motherhood.
Hello, my name is Esther Whitney. I'm an autistic mother, student autism researcher, and an artist. Thank you for taking the time to join me on my presentation in Understanding Autistic Motherhood. I hope you find it informative. This painting explores the impact on families in relation to having a child wrongfully removed from their care because of lack of understanding and knowledge. It is emotive, it's difficult to look at, but it's important to acknowledge that when there is an absence of knowledge and understanding, the consequences can be catastrophic. The parenting experience is different for autistic people. Knowledge and understanding can make a huge difference to an autistic parent's life, leading to positive perinatal experiences. We should not be held to neurotypical parenting standards. We are autistic, we will always be autistic. Our parenting styles and experiences are different, not wrong. The more this is recognised and understood, the better we are received by society. The above word art are extracts taken from 3 research papers looking at experiences of autistic motherhood, and some are of my own experiences. As you can see, we have a lot of strengths, and I hope that you'll also see how much emotional warmth, love, and empathy autistic mothers report. There is a misconception that autistic parents are emotionally cold. Professionals need to advocate a change in narrative in relation to autistic parents. A move away from the deficit approach is much needed. The adoption of the difference narrative would benefit all. We all have strengths and weaknesses, whether we are neurotypical or not. The same goes for autistic parents. We can bring a lot to the table. In 2016, I had my daughter. Unfortunately, because of a lack of understanding in relation to autistic parenting, many of my experiences were echoed within the United Kingdom Human Rights Committee report, written by Blakemore in 2015, outlining human rights violations against autistic parents. No woman should need to consider system failure and rights violations as part of her future reproductive choices, Blakemore 2015. I'm sad to say that as an autistic female, I'm having to consider my reproductive choices very carefully. This is due to system failure, along with my own experiences of rights violations within child protection. In other words, as it stands currently within the UK, I do not feel able to have any more children because of lack of professional understanding around autistic parents and neurodiverse families, and the absence of tailored support. Sensory processing in autistic mothers, pregnancy and birth. Autism sensory processing in pregnancy. It is important that professionals have an awareness around the differences experienced by autistic mothers during pregnancy. Without awareness, there is a potential for autistic mothers to be misunderstood, resulting in unfair treatment and distrust of services. Pregnancy can be a challenging time for any mother. However, for autistic mothers, the challenges are often atypical. This can make pregnancy even more challenging due to the absence of understanding from professionals, lack of tailored support, and non-existent adaptations to services. During pregnancy, many mothers reported experiencing sensory experiences heightened to the extreme, maternal experiences of being pregnant difficult to cope with, medical appointments during pregnancy difficult to access due to sensory and social barriers, severe and prolonged sickness, difficulty in changes in body, and the difficulties adjusting to maternity clothing. Autistic mothers reported finding natural labour very challenging, overwhelmed by sensory stimuli within the hospital setting, along with the sensory stimuli of the actual labour process. Many autistic mothers described medical professionals failing to understand and support, resulting in inadequate care. What has come to light is the lack of awareness around masking during labour, resulting in autistic women not being believed about their pain. Some autistic people have co-occurring alexithymia, which could result in differences in recognising pain and distress. Some autistic women reported having a planned caesarean section was very comforting because of the predictability and formulaic process. While natural birth can be rather unpredictable, it is noteworthy that planning and communicating the process could be helpful. Autistic people do struggle with change. However, we can and will adjust. Becoming a parent is a massive change. More awareness from professionals in the importance of transition planning and with autistic parents from pregnancy to birth could lead to positive experiences. Misunderstanding autistic burnout in new autistic mothers. It's unrealistic to expect autistic parents to be able to parent long term. This is a quote from my medical records when I was in a mother and baby unit. Looking back, it was clear that at the time I was experiencing autistic burnout. This was misunderstood as an inability to be able to parent long term. Autistic burnout is a likely possibility in new autistic mothers. However, it is possible for this to be misunderstood by professionals, as some of the symptoms could be misinterpreted as postnatal depression or other conditions. Recovery could be difficult to implement within mother and baby unit settings, as these units are not designed for neurodivergent people. It is important for staff to have an awareness of the signs and symptoms of autistic burnout, and for these to be reflected in observational notes. awareness of autistic burnout will enable staff to support burnout recovery and prevent damaging assumptions being made regarding the parent's ability to parent. Breast or chest feeding on the spectrum, a kaleidoscope of intense sensory input. A high proportion of autistic people identify as non-binary. It is important that this is reflected within perinatal support. This painting explores my experiences of breastfeeding on the spectrum. I have used colour symbolism to represent the spectrum of intense emotions and sensory input I experienced. Supporting autistic breast or chest feeding mothers. We would like to see professionals supporting us and encouraging us. We would like to be able to verbalise the challenges being autistic breast or chest feeding parent can bring, without fear that this will be used against us. Autistic mother Bex Harper, who is an Association of Breastfeeding Mothers supporter, asked a group of autistic mothers on Facebook how they would like to be supported by professionals, and here are a few of the key points. Autistic needs to be considered when seeking, assessing and receiving breastfeeding support. Be mindful of sensory processing differences. Some autistic people experience hyposensitivity, others or autistic people can experience hypersensitivity. Get a feel for the level of knowledge the person you are supporting already has. Be able to back your support with further research and let the mother know that this is available for her to read and interpret herself. Be reliable. Anxiety is likely to be high. Communication is very important. Find out mother's preferred communication methods. Some autistic people find telephone calls difficult. What needs to change? Training and awareness from university level. I would like to see universities raising awareness around autistic perinatal care in courses such as midwifery, mental health nursing, and social care, etc. It is fair to say that these services have been designed for one neurotype. Therefore, it is paramount that we are nurturing the next generation of professionals so that they have the ability to automatically adapt their practice, which will provide autistic parents with better experiences and outcomes. This year, I wrote to a number of midwifery courses, highlighting the need for better awareness around autistic perinatal experiences for their midwifery students. Unfortunately, I have had very little response. I want to see universities being willing to open these discussions within the autistic community. Local authorities and NHS perinatal services implementing specialised updated training around autistic parenthood. I'd like to see perinatal services working alongside the autistic community in order to provide the most relevant and up-to-date training for their staff. In 2021, I wrote to every mother and baby unit in England, Wales and Scotland, highlighting the need for specific autistic parenting training. To date, only one trust in the Midlands recognised the need for more support. I had the pleasure of training a group of perinatal professionals from the trust. The feedback has been that the training has led directly to better outcomes for autistic mothers. Early support for autistic parents, autistic breast/chest feeding support. Thank you for taking the time to listen to my presentation. I will now hand over to the chair of this session, who will introduce the next panel presentation. Please save any questions you have until the end of the session, where I'll gladly answer them in the live Q&A. Thank you.
Thank you, Esther. That was a really moving presentation. Thank you for highlighting the issues that can affect autistic mothers and the ways of supporting people with this, as well as your efforts in raising awareness among health professionals. I'll now move on to our final speaker, Sara King, who will be talking about a related topic, maternity services. Now over to Sara.
Hello, I'm Sara King. I'm 4 years into a part-time PhD within the Autism Centre for Education and Research at the University of Birmingham. I'd like to tell you about my research project, which is how do maternity services support autistic women and birthing people as service users and the staff who support them, and what improvements can be made. It's estimated that 1 in 67 people are autistic. Autism in women and girls has not been known about or understood until fairly recently, and as awareness and diagnosis increases, services will need to respond. This project was driven by my own personal interest as an autistic mother. Also, I lead a women's group for autistic women and a parenting group for autistic parents. The driver for me is to improve services to support autistic people. I carried out a survey about autistic women's experiences of maternity services as part of my PG DIP, and my PhD was developed from that. This project has been peer-reviewed by the Autistica network, identifying it as a research priority for autistic people. I was awarded Charles Showland funding, which is part funding the project and allows me to compensate autistic participants in the second phase of data collection. The materials have been piloted and sense-checked by an autistic doula and an autistic mother. And although there's a distinct lack of literature, the need for practical specific support has been identified. I wanted to find out what the context is in terms of statistical information and policy, what experience and understanding maternity services staff have about autism, and what the experience of autistic women and birthing people as service users of maternity services is. Autism is a protected characteristic, and there's an obligation to ensure that autistic people can access services. Barriers for autistic people accessing health services generally has been identified. This is an important time for anyone, but autistic women are more likely than the general population to need different support. Responses to my previous project demonstrated real challenges that autistic people experience relating to maternity services, and good practice for autistic service users will benefit all service users. The project is a heuristic inquiry, an approach that requires that the researcher has personal experience of the topic being explored, and it requires voices other than just the researchers in order to explore as many facets of the experience researched as possible. I'm using a mix of methods to attain qualitative and quantitative data. I carried out freedom of information requests for context. An online questionnaire collected data from maternity services staff. In addition to checks I've mentioned already by autistic people, as I don't work in maternity services, they were also sense-checked by a chair of a Maternity Voices partnership and a member of staff at the Royal College of Midwives. I've carried out interviews with a subset of questionnaire respondents, and I'll be interviewing autistic people about their experiences next. Throughout the project, there were many changes, and I had to adapt my approach as I went along. Firstly, the freedom of information process just didn't provide the robust statistical information that I'd hoped for. In reality, that just wasn't there. The impact of COVID and resourcing issues in maternity services impacted on the recruitment process, and this has made me especially grateful for the time that staff have generously shared with me. Because of the under-target response, I focused on the interviews. The target was for 5, and I carried out 18. But then the questionnaires started coming in, so I now have a wealth of data, both qualitative and quantitative. I'm using SPSS to analyse the quantitative data and using Brown and Clark's thematic analysis to analyse the qualitative data using NVivo as a tool. The findings will inform the questions in phase 2. The questionnaire asked a range of questions about experience and knowledge of autism, training and work processes. Detailed analysis is underway, and I'd like to just share some headline findings. I had 99 questionnaire responses. Apologies that this slide has lots of info on it. The main point I want to share is the lack of diversity in my participants in terms of ethnicity and gender. I'll be comparing this to the general population of maternity staff as part of my analysis. 71% of the respondents were midwives, 8% were maternity services workers, 5% were consultants, and 16% were a mix of other roles. 81% said they had not received any autism training since starting their role. 19% said that they had. When asked, how important do you think autism training is for your role, 72% said that autism training was either extremely or very important for their role. 83% said that they had gained understanding of autism outside of their role from experience or training. This included 13% who said they're autistic. Given that it's estimated around 1.5% of people are autistic, this data had a high proportion of autistic respondents. 40% said they had an autistic family member, and some individuals may have been in both of those categories. Of those who said they had understanding and experience of autism from outside of their role, 85.5% said the fact they had this understanding and experience would affect how they would support an autistic person. This raises questions for me about those that don't have that personal experience and understanding and haven't had any training. How are they then supported to support an autistic person? I'd like to share some headline findings from the interviews. The participants were a subset of questionnaire respondents. Of the interview participants, 4 individuals were autistic, 1 was awaiting diagnosis, and many of the participants have autistic family members. 18 interviews have been completed, about an hour to an hour and a half for each, providing lots of rich, detailed data about staff knowledge, policies, practice, and training related to autism. At the time of recording, thematic analysis is underway using Brown and Clark's 6-step process, and detailed findings will be available soon. Let's just share some of my initial thoughts. Many of the participants talked about misunderstanding, lack of knowledge about autism, and stigma that they believe exists in services. And they felt that with understanding and training, that maternity services staff would want to support autistic people to the best of their ability, but without that training, the lack of understanding is affecting services. The personal experience these participants have of autism has led them to having practical understanding and a real passion for making improvements for autistic people. There are many suggestions for improvements and mechanisms for implementing improvement. There's a need for national guidance for maternity services and maternity-specific training. Better understanding is required more generally throughout hospital services, but there are some issues that impact in maternity-specific situations that require more targeted training and understanding. The analysis of findings from the interviews will inform the next stage of interviews with autistic women and birthing people. Within the data, there are examples of autistic staff or those with autistic family members becoming powerful advocate voices in their organisations, sharing knowledge and upskilling staff. There were several examples of maternity staff undertaking autism research and making practical materials to drive change. Autistic staff are self-advocating and upskilling their organisations about what their own needs are in the workplace. It's crucial that understanding and support for autistic staff is made available. And it reinforces that this is a whole community issue. We need that understanding across the board. And there was also mention of autistic partners. Some barriers to change were identified. These included resources, funding, staff and time. And one participant said, "I think I'm probably not saying anything you haven't heard from anyone else, that we're stretched in staffing to provide the level of service we would want to." And another said, "Money, time, shortage of staff, lack of training in terms of confidence in the subject. I think those are barriers." Another barrier was other nationally driven priorities, with a participant saying, "There's lots of national strategic priorities around the safety agenda, fetal monitoring training, those sorts of things come out top of the list in terms of where the focus is." Another barrier is a lack of understanding of the need, with the participant saying, "Some people just won't care enough about it, but they don't care less, they don't care enough." And another said, "I really don't think it's given a lot of thought by people, as in, I don't think they often consider autism." On the other hand, some enablers for change were identified. Staff want to do an excellent job, with a participant saying, "Midwives want to do the best thing by the people that they work with. That's the bottom line." Another enabler was that increasing understanding of autism, with one person quoting, "The research is emerging. You know, people are starting to look at maternity services and autism, and it was just so under-researched, and that's changing." There were lots of practical suggestions for improvements, and recommendations are to be developed. Carrying out the project as a heuristic inquiry and sharing my own personal experience led directly to practical outcomes. One Trust plans to share my personal story as part of their mandatory training for maternity services staff, and also carrying out the project provided me with direct contact to others with an interest in this area, which allowed me to set up MARGE, which is Maternity Autism Research Group. It's made up of individuals with an interest in maternity services, research and improvements. Most of us are autistic and we're cross-institutional and multidisciplinary. The website is due to go live shortly and will host and signpost research, resources, materials and support. Thank you very much for watching. Please get in touch with me if you'd like more information. I'd like to thank all of the participants who have generously shared their time, especially given the pressures in services over this time. I'd also like to thank everyone who's got in touch about the research, asking questions, requesting resources and information. It really demonstrates the need for research in this area. And finally, I'd like to thank my supervisors, Dr. Andrea McLeod and Dr. Caroline Richards from the University of Birmingham, for their ongoing support and enthusiasm. Thank you. I'd like to hand back over to the chair, and I'll be really happy to answer any questions you have in the question and answer session.
Thank you so much, Sara, for your presentation. It was really great to hear how your research and lived experience is having an impact. I think that will be so important to so many people watching today, that autistic parents get the right support from maternity services. So we'll now move on to the Q&A session, and I'll just invite everybody to, all our panelists to switch their cameras on. Okay, I think that looks like everybody. So the first question is for Barry, and the question is, when do you think your research outcomes might become part of NHS practice?
So, well, I think it's a really important question, and one that's key to the research that we're doing, and the clinical research, really about trying to think about how some of this goes into practice and is implemented into practice. I think there's a couple of things to say. One is in the context of, as I was mentioned at the end of the presentation, the health check for autistic people study and trial, which is funded by Autistica and also NHS England. And the important thing about that is that there's within the context of NHS England, there's a commitment to pilot health checks for autistic people, and though that pilot will be using the materials that we've developed and which are based on the research that we talked about, and then looking at trying to roll that out and implement it beyond the pilot. So the process of trying to implement some of the research findings into practice across England, into primary care, is already underway, and hopefully will progress as we also do the trial. So I think that's one sort of formal way in which some of these the research findings have been implemented in practice. I think the other bit is as that sort of more formal work is going on, there's the kind of slightly more informal dissemination and just sharing some of this practice in sessions like today, but in other sessions with clinicians, GPs, and other clinicians in secondary care, mental health, and so on. Where we're just trying to share some of the findings, share some of the views of autistic people about the barriers that people are facing, and some of the things that might work in terms of overcoming some of those barriers, some of the reasonable adjustments to healthcare that may at least give access to healthcare, and hopefully access to more effective healthcare. So I think there's that formal and slightly more informal ways in which we are just trying to get some of the research findings into practice. Thanks.
Great, thank you. It's really good to hear kind of the impacts that your research is starting to have. So the next question is for Katelyn, and the question is, how do we plan to get buy-in from GPs performing the health checks, given the capacity and funding crisis currently happening in GP practices?
Yeah, thank you for that question. I think it's a really essential piece of the puzzle, and the reason that we thought that this work was kind of important to do in the first place. We took a really kind of pragmatic approach to this and recognized that the NHS is in a really kind of challenging position right now, especially as COVID is an ongoing kind of situation. There's also lots of other things happening in the environment. So the kind of way that we approached this problem was thinking both in terms of this is a really important thing to do, and also recognizing that there are other kind of competing objectives that GPs have. And so the recommendations that we landed on were kind of really came in the bucket of three things that we think can kind of happen simultaneously. The first one being to be a bit creative about who should be doing health checks. So GP services, there are GP physicians who work there, but then there are also practice nurses. There are other healthcare professionals who work in that environment. And a lot of the kind of components of a health check are things that are well within the scope of capabilities of those other healthcare professionals. And so we thought that that might be a way to make sure that things like this happen is to make that part of the scope of the job description for other healthcare professionals who are not physicians, especially because they tend to have a bit more time on their hands than GPs themselves. The other thing that we think would be quite promising, and something that we hope that NHS England would be happy to work with GP practices on, is supporting them to kind of make this as logistically and technologically as streamlined as possible. So again, people told us that in staffing and time were the two things that were the most challenging for them, that their funding challenges really came down to figuring out who is going to do it and the extra time that things are going to take. So we thought that to the extent possible, if we could kind of make sure that things are streamlined and automated and kind of piggybacking on systems that already exist and people are familiar with, can kind of lessen the load in terms of trying to bring on board a new service. And then the final thing is to really make that case for why annual health checks are the thing that we should be doing, making it really, really clear both the impacts on autistic adults themselves, and then, the kind of, to the extent that we can, make the case for these are things that have long-term health impacts, and that those are kind of things that have downstream impacts on the health service itself as well, that early intervention and early picking up of health challenges is also kind of beneficial for all of us. And so being able to demonstrate that case, I think, is a really important piece of the puzzle. Yeah, I guess I'll leave that there.
Thank you. I think that's a really important point about the long-term outcomes as well, and how it's important to have that preventative care in place. Thank you. The next question is for Rachel, and so the question is, as autism awareness increases and more autistic people get diagnosed at an earlier age, could this lead to lowered impacts of stress and better health outcomes in autism as people better understand their difficulties and develop strategies to better manage their stress and anxiety?
Thank you. What a fantastic question. I love that question. I think the first point to say is we hope so. There isn't a lot of research out there right now to see the impact of late diagnosis versus early diagnosis, but there is a limited bit of research that suggests that late diagnosed autistic people do actually struggle more with their mental health, with things like self-injury, with depression, with social difficulties. So already there is some research suggesting that children who are diagnosed in later childhood struggle more, and they continue to struggle more as they get older. On the other hand, there's also research that suggests that promoting a positive autistic identity, so really based on a neurodiversity framework, and making a child aware and able to understand early on that
yes, you notice that you're different, and this is why, and it's not a bad thing. There's increasing evidence that this is a very helpful thing in terms of people's well-being. So although there isn't a lot of evidence base out there right now, we would hope that some of the stress impact, some of the stress load on autistic people might be reduced. However, I want to make a very important caveat there, because a lot of the stress load on autistic people comes from outside them. It comes from systemic injustice and inequality, and lack of appropriate provision at many different levels, as we've heard this morning. So it's certainly not, it's a far more societal issue to reduce the stress on autistic people. It doesn't just come down to whether or not they know they're autistic and the people around them know. Thank you for such a great question.
Thank you for your answer. That's a really important point as well that you make about the societal impact. The next question is for Susan. And do you have any advice for a parent with an autistic child with gastrointestinal issues who is facing unsupportive healthcare practitioners? Have we got Susan on the feed? It doesn't look like she's able to come in at the moment, so I'll go to the next one and then we'll see maybe whether she's able to join in a minute. So the next question is for Kate, and what lessons can we learn for self-identity with gender and neurodivergence without medicalising identity?
Yeah, it's a brilliant question, and there's lots in there. So I think the person's asking about self-identification, so kind of identifying as transgender and then identifying as autistic, and the medicalisation of both of those identities. So I'll take each one in turn. So as I said in the presentation, the autistic and gender diverse people I spoke to, both young people and adults, were really clear that they were able to self-identify in terms of their gender. But some of the network around the young people I spoke to were kind of concerned that maybe their gender identities, young people's gender identities, might change in future. And that is definitely something which kind of plays out in gender clinic settings, which is a real challenge for everybody in those settings. And I think, you know, this is a relatively small qualitative study, and we really do need a lot more quantitative research around, for example, different gender trajectories, actually in young people in general, not just autistic young people. And I think that research really needs to come from a position of tolerance for all different types of gender journeys. And I think the field is so politicized at the moment that that can be a challenge. And I think that does actually impede some research happening sometimes, which is such a shame, and it does a disservice to gender diverse and neurodiverse people. I think we also need more research on outcomes of kind of physical gender transition for autistic people. I mean, given the prevalence of autistic people in gender clinics, we can assume that they are included in some of the studies looking at outcomes, but we do need studies looking specifically at neurodiverse people as well. And about the kind of medicalisation in relation to gender, I suppose actually in this study, it was an inclusion criteria that the autistic people had to have asked for help from professionals around their gender identity. So they didn't have to meet the kind of DSM criteria for gender dysphoria, but they did have to have asked for professional help. So in some ways, we were deliberately sampling a group of participants who were distressed and asking for professional help. So we kind of were using a medical, in the direction of a medicalized definition. And I think we do need more research without those medicalized definitions, and more research about kind of positive experiences of gender in autistic people and other neurodiverse groups as well. So then in relation to autism, I think a really interesting interesting finding from this project was that young people were actually less interested in talking in the interviews about their autism identity as compared to the autistic adults. And this is me speculating, but I do wonder about how invested some of the young people were in their diagnosis, if they had that when they were in primary school, maybe didn't fully understand the process, and so didn't have the same level of investment in their identity. But what's really interesting is that the adults I interviewed, half of them were diagnosed in childhood. So actually it seems like developmentally moving to adulthood, maybe they became more invested in that identity as they got older. And certainly almost all of the young people I spoke to spoke about really distressing experiences in school of being discriminated against, being bullied in relation to being both neuro and gender diverse. So I think adolescence could be a real moment of opportunity to help autistic people feel more positively about their identities. And it would be really interesting to kind of understand the perspectives of those who are really invested in their diagnosis, or have self-identified without a diagnosis, as compared to those who've maybe had a diagnosis but don't really self-identify. So I think there's just a lot more work that we need to do to really fully answer that question.
Thank you. I think those findings are really, really interesting. And yeah, thank you for highlighting kind of the need for more research, and also that, yeah, the challenges of the current political context must be quite difficult to do some of this research at the moment. The next question is for Esther. And it's, do you think that postnatal depression is avoidable in autistic mothers, or is it an inevitability? And could it be prevented? Or is it a matter of reactive measures after developing it?
I think for me, I'm quite cautious in saying it's inevitable, partly because of, so from my experience, that was the assumption. When I had my daughter, I had a diagnosis, well, I have a diagnosis of autism, but I also had a misdiagnosis of EUPD, emotionally unstable personality disorder. And all the professionals involved just decided that it was a given that I would have postnatal depression, hence why I was put in a mother and baby unit. The issue is that the mother and baby units, they didn't have the training or understanding in relation to autistic parents, and none of my autistic needs were met. And also mother and baby units are very social environments, which subsequently led to autistic burnout. I think as well, like, becoming a parent is a very social event, and so again, I think there needs to be more research and discussions around postnatal depression, autistic burnout. Also, it's just a huge life change. I think that there is not enough support specifically for autistic parents. It's just completely like non-existent. When I had my daughter, there was like literally zero research, like apart from the paper by Monique Blakemore in 2015. Obviously that's starting to change now, but it's very, very slow. And yeah, I think these discussions need to be had. I don't think that we can say it's inevitable, because there isn't the support there and there isn't the research there. So I don't know if that answers the question.
Yeah, no, definitely. I think you're so right that it's, you know, the research in this area is so under researched at the moment. So we definitely need more to kind of answer those sorts of questions. I thought your point about the social and environmental aspects of motherhood is really a really good point as well, that maybe people could research more.
I think also as well, the role in co-occurring alexithymia is something that really does need to be taken seriously, because a lot of autistic people have co-occurring alexithymia. A lot of practitioners have never heard of it, have no understanding. And so this can be quite a pitfall, because when
practitioners are asking an autistic parent how they're feeling, how they're feeling about their baby, and the answers are, well, I don't know. You know what I mean? Because people with alexithymia struggle to verbalise their emotions. Again, that could lead to not helpful things. So yeah.
Yeah, no, definitely. Yeah, you're absolutely right. I think, you know, there needs to be a better understanding of all of these concepts in there. The next question is for Sara. And the question is funding and lack of staff capacity an issue in maternity services being able to give good care, and how can we encourage training and personalisation when services are stretched?
Thanks, Charlotte. Yeah, I think we've heard this across most of the threads of the presentations today about funding, resourcing being an issue and a barrier, and definitely from the research and from the data I'm analysing now, most of the participants have talked about funding, resourcing, time, other staffing issues generally being a real difficulty, and that COVID has impacted on that. I think in the past, some of my respondents have talked about staff may have had the willingness and the time to go and research themselves and find out more, but at the moment even that's really difficult because the challenge is so high at the moment. So I think in terms of the stretch, I think staff having the time out for training is an issue. Currently at the moment, my research data is showing that even having staff out for the mandatory training is really difficult, where staffing is, people are off, people have COVID still, these things are difficult. But there are some drivers for change here. One of those is this drive for individualised care that's coming through services, and that's a real opportunity to make change. And obviously, that's crucial to support autistic people. And the approach towards more continuity of care is another opportunity to make change here. The research is increasing, and Esther's spot on. There's loads that needs to be done still, and bringing autism higher up on the agenda is starting to happen. And I hope it will get to a national level and then become part of mandatory training. So as that awareness is increasing, more people are receiving a diagnosis or having that awareness that they're autistic, and then self-advocating. And as people are diagnosed as children and growing up, having that awareness of their own autistic profile and what their needs are, and self-advocating and advocating for others, I think that change will have to happen. But there's a lot that needs to do still, but I think there are real mechanisms and opportunities to make those changes. And I think the research we've heard about today is all part of that.
Yeah, thank you. It's definitely a challenging context at the moment, but thank you for highlighting what some of the opportunities are, and hopefully people will be able to take that on board. I'll just go back to the question for Susan, and we'll just see whether she's able to come in on that. So Susan's question was, do you have any advice for a parent with an autistic child with gastrointestinal issues who is facing unsupportive healthcare practitioners? Sorry, everyone. I think we're possibly struggling to get Susan on at the moment. There is a question for sort of for anyone to come in on. So the question is, if you've experienced invalidation in healthcare settings and past difficulties accessing healthcare, so meaning that you might now fear and avoid accessing the healthcare that you need, what can autistic people do to improve their access to healthcare and communication with their clinicians when people have had those experiences?
I'm happy to say something if that would be useful.
Okay.
So I actually shared in my presentation the worksheet, which is for autistic people to share information about autism and communication preferences and kind of sensory needs in clinic settings, which I'm trying to share with clinicians so that they kind of preempt those needs and fill out that form with autistic patients in their first appointments. But as an autistic person, you can download that worksheet and kind of share it, and it's then kind of structured and written down. So if you are someone who kind of knows your needs in advance, then that's something that you could do that might be helpful. And I think I sent the link in the chat, so I'm not sure if that can be shared around.
Okay, yeah, I'm sure we can look into sharing that. Did anyone else want to come in on that question?
Yes, please. I'd like to. Just to add to that, I think that sort of pre-identifying of your own needs and having that prepared is a really great idea. And I'm aware of a couple of maternity services passports that have now been developed, and we'll be hosting those on the Marge website when that's available, and I can signpost some information that perhaps can be circulated afterwards if that's helpful. So I think just being prepared, sort of having something with you, and perhaps if you can have somebody with you that can support with that. I mean, maybe that's an option too for some people. Yeah.
Thank you, that's really fantastic. So we're just a little bit over time, so I think we're probably going to wrap up there. Thank you very much for watching, and see you again soon.